In the rest of this talk, we will discuss the complications of ALF that we mentioned briefly in the assessment section. At all stages of the disease, we need to be on the lookout for these life-threatening events. Hypotension and cardiovascular dysfunction are common findings and are multifactorial. There's often low effective blood volume from poor oral intake and fluid losses. There's vasodilatation due to systemic inflammatory response, which may lead to shock. Low systemic vascular resistance and buildup of toxic metabolites may lead to high-output cardiac failure and myocardial injury, which can worsen liver injury. Relative adrenal insufficiency and related cardiovascular morbidity has been proposed as a mediator of organ dysfunction in ALF. However, the role of glucocorticoids in ALF is unclear. The management approach here is similar to other critical illnesses. Early volume resuscitation is key and mitigates the severity of organ failure. Goal mean arterial pressure is 65 to 75 in order to maintain cerebral perfusion pressure. If response is inadequate to fluids, we move to vasoactive drugs or pressors. Norepinephrine is the preferred vasopressor, while epinephrine and dopamine may be used as second line. Vasopressin should be used with extreme caution in patients with intracranial hypertension. A trial of hydrocortisone should be used in patients who are unresponsive to fluids and escalating doses of pressors. In order to get a better assessment of fluid status, a PA catheter can be considered. An echocardiogram is also useful to assess myocardial dysfunction. The need for ventilator support in ALF goes hand in hand with the grade of encephalopathy. For patients with encephalopathy grade 3 and above, we intubate and sedate for airway protection, control oxygen and carbon dioxide levels, and prevent aspiration pneumonitis. Respiratory dysfunction as a consequence of the liver failure is uncommon in the early stages, but acute lung injury or ARDS can occur later during hepatic regeneration with nosocomial sepsis.
Encephalopathy is a key feature of ALF. The grading of encephalopathy developed in West Haven, Connecticut is still in use, and the critical point is at grade 3 when patients become clearly altered. Encephalopathy develops due to the impairment in the normal detoxification of ammonia to urea. The reason why progression of encephalopathy is important is that it can lead to cerebral edema and from there to intracranial hypertension. Although intracranial hypertension is seen in only a minority of patients in the U.S., if it develops, the rate of survival without transplantation is poor. The key here is to prevent the development of cerebral edema, or in the cases where there is cerebral edema, to limit its severity and the development of intracranial hypertension. It is important to monitor the patient's neurological status closely. For patients with encephalopathy greater than or equal to grade 3, we intubate and sedate, generally with propofol, which reduces cerebral metabolic rate. We do a CT of the head to evaluate for cerebral edema, and we consult neurology and neurosurgery to consider ICP monitoring. Hypertonic saline has been shown in studies to delay the onset of intracranial hypertension. For any patient with grade 3 encephalopathy, serum ammonia greater than 150, or AKI requiring renal replacement therapy, we prophylactically start hypertonic saline to induce hypernatremia to a goal plasma sodium of 145 to 155. We also induce hypothermia. This works by slowing body metabolism, lowering systemic production of ammonia and its cerebral uptake and metabolism. It also has hemodynamic stabilizing effects and reduces cerebral blood flow. The recommendation is to avoid fever and cool the body to a core body temperature of 35 to 36 degrees. However, there are more recent AGA guidelines that do not endorse hypothermia, so this is a matter of local protocol.
Bacterial and fungal infection occurs in 80% of patients. Pathophysiology involves impaired immunoglobulin and protein production by the liver, and the resultant immune dysfunction. Impaired Kupffer cell function. Kupffer cells are macrophages that line the liver sinusoids and remove 99% of pathogens from the portal blood. Common pathogens are staph, strep, and gram-negatives. The treatment of infections is important because infections can preclude transplantation. They can also contribute to worsening encephalopathy. Prophylactic antibiotics have not been shown to have a survival benefit. Therefore, they are not indicated across the board. However, given the likely role of inflammation in the development of encephalopathy and cerebral edema, antibiotic prophylaxis can certainly be considered. Baseline pan cultures of the sputum, urine, and blood should be obtained, and they should be repeated at regular intervals. We must keep our suspicion high and have a low threshold to start antibiotics. In ALF, some degree of coagulopathy and low platelets, around 100, is expected. Coagulopathy is due to the decreased production of clotting factors, and thrombocytopenia is due to consumption. The recommendation is to correct the coagulopathy only in the setting of severe coagulopathy, for example with INR greater than 7, or for control of bleeding or in anticipation of invasive procedures. INR is the most sensitive predictor of liver failure, and the temptation to correct coagulopathy should be resisted. If reversal is indicated, we use vitamin K, FFP, and recombinant activated factor 7A. In terms of the thrombocytopenia, we stick to normal platelet transfusion thresholds.
The final complications we will talk about are renal dysfunction and metabolic issues. 30 to 50% of patients with ALF have renal dysfunction. The underlying reasons can be multiple. It may be due to dehydration or often acute tubular necrosis. Acetaminophen is directly toxic to the renal tubules. The acute development of processes underlying hepatorenal syndrome, such as portal hypertension, splanchnic vasodilatation, decreased effective arterial blood volume leading to activation of the renin-angiotensin-aldosterone system, may also contribute. Renal failure often resolves with the resolution of liver failure. To support renal function, we should have good control of hemodynamics and avoid nephrotoxic agents, and we should always be on the lookout for indicators of the need for renal replacement therapy. While the AEIOU mnemonic is helpful in determining the need for renal replacement therapy in the general population, patients with ALF are often started on renal replacement therapy before such symptoms develop, and continuous forms such as CVVH have been shown to achieve greater metabolic and hemodynamic stability. In addition to renal dysfunction, there are many other metabolic concerns. Phosphate, magnesium, and potassium levels are often low, and they require repeated supplementation. Patients with ALF are at increased risk for hypoglycemia due to the loss of hepatic capacity for glycogen storage and gluconeogenesis. To prevent this, we check fingerstick blood glucose frequently and use a continuous IV glucose infusion. If we go back to biochemistry, the liver is involved in synthesizing non-essential amino acids and cholesterol, as well as converting protein and carbohydrate to fat. The dysfunction of these processes puts patients at high risk of muscle loss and impaired healing. In order to prevent this, we give 1 to 1.5 grams of enteral protein per kilogram per day. Although parenteral nutrition can be considered if there is a contraindication to enteral methods, it would put patients at high risk for infection, especially by fungal pathogens.
At this point, we establish that our patient fits the criteria of ALF, and we are ready to write our note. It is appropriate to do this in the format of an ICU note, as almost every organ system may be affected. A good place to start in our assessment is to consider a differential for etiologies. This will pull in from mainly the history and physical exam, focusing on the time course, risk factors, and the patient's clinical state. Then, very importantly, we want to give our reader an idea of how sick the patient is, and whether they're improving, staying the same, or declining. What is their prognosis, and how worried are we about the need for transplant? In our plan, if the underlying reason is drug toxicity or mushroom poisoning, this should be at the top. We should talk about what agent, such as NAC, is being given. Starting with the GI system, we want to talk about liver function tests, severity of elevation and trend of aminotransferases and bilirubin, symptoms such as abdominal pain, nausea, vomiting. We should always have a transplant section to document that we contacted the transplant team and their recommendations. It would be appropriate to include King's College criteria here to support our plan. We would then cover the cardiovascular system. What is the patient's hemodynamic status? Are we giving fluids, pressors, steroids? What's our MAP goal? Is the EKG echo normal? Are we concerned for myocardial injury? Thinking next about their neurological status. Are they awake, alert, or in a coma? We must document mental status frequently, including performance on repetitive tasks, like serial 7s, and whether the patient is developing hyperreflexia or clonus. How concerned are we about their mental status or the development of cerebral edema or intracranial hypertension? What is their ammonia level? Remember that ammonia level greater than 100 is a risk factor for the development of cerebral edema and intracranial hypertension. Are we measuring their cerebral pressure? Are we employing any interventions to decrease the risk of intracranial hypertension, such as hypertonic saline? For the pulmonary section, we can comment on whether they're intubated, sedated. If not, how stable is their airway? Moving on to infections, are we concerned for an infection? Are we giving antibiotics? Is there any growth in the blood cultures? For renal section, we should comment on their electrolytes and presence of any factors under the AEIOU category that may necessitate renal replacement therapy. If they are getting renal replacement therapy, how are they handling it? For heme, we can comment on their hemoglobin, platelet count, and INR, and signs and symptoms, and the risks of bleeding. Have we given vitamin K, FFP, transfused any blood or platelets? For endocrine, how is their blood glucose holding up? Finally, we should talk about their nutritional status. Are they able to eat on their own? If not, is enteral or parenteral nutrition being given?
In this final slide, we will recap this presentation on ALF with some key take-home points. ALF is defined by the onset of jaundice, encephalopathy, and coagulopathy in the past 26 weeks in patients without a history of liver disease. It is significant because these symptoms indicate an acute decline in previously normal people. All patients who exhibit abdominal symptoms with confusion should have their INR checked to rule this out. ALF patients are very sick by definition. They often develop derangements in multiple organ systems and have the potential to experience life-threatening complications. Initial workup should focus on cardiovascular, neurological, and metabolic stability. The best place to manage an ALF patient is in the ICU. The transplant team should also follow the patient. If an ICU or liver transplant is not available, it is important to transfer the patient to a facility that can provide these early in the process when the patient is neurologically stable. Potential etiologies of ALF are broad. The most common cause in the U.S. is acetaminophen toxicity, and this should not be missed. Others are mushroom poisoning, viral infections such as hepatitis A, B, and E, and others, as well as pregnancy, autoimmune disease, Wilson disease, neoplastic processes, and Budd-Chiari syndrome. Although all patients with ALF should have an acetaminophen level checked, the rest of the workup should be directed based on suspicion. For all etiologies, liver transplant can be considered early in the process. King's College criteria is a validated prognostication system with good specificity but poor sensitivity, which can lead to unnecessary transplant.
And this is the end of our presentation, the Yale20 on acute liver failure. For any questions, please feel free to email sarah.omer@yale.edu. Thank you for listening.